There's one facet and one perspective that we haven't really approached yet. And it's one of the most important ones and probably the reason that we're all here. And that is the patient's perspective. So that's what we're going to look at and explore in our next panel. Our moderator on the patient story will be David Livesay. David works with our exceptionally talented group of individuals in MiHIN's Marketing and Communications Department to understand the Michigan marketplace and the national landscape, and to position Michigan as a leading voice and resource within the complex, dynamic health information sector. David and his team are responsible for hosting this annual Connecting Michigan for Health conference, where change makers and industry leaders like yourselves are taking Michigan and throughout the U.S. to gather together and share how we're all improving health information exchange. Ladies and gentlemen, David Livesay.
Thank you, everyone. I am particularly happy to moderate this session for two reasons. Number one, I typically move around quite a lot during the conference, and this is my chance to not move around quite so much. And number two, as the parent of a child with a complex health condition, I've experienced a lot of the things I think that are going to be discussed today. And my wife and I experienced that before there really was such a thing as health information exchange. And if it weren't for a fiercely loving and protective wife, my son would not have been able to make the progress that he had made through the health system. And so I'm going to be fascinated to hear how much of that is still the same and how much of that has changed and improved over time. So I'm going to introduce our panelists in alphabetical order. Megan Brodie is a community relations specialist at MiHIN. Before joining the MiHIN team, Megan worked as a clinical social worker at a variety of agencies as a psychometrician, therapist, and care coordinator, assisting individuals with a wide range of needs and mental health diagnoses. She volunteers with Early On Michigan, sharing her personal story of receiving services from Early On and providing support to parents of young children going through similar experiences. Megan received her bachelor's degree from DePaul University and her master's degree in social work from Michigan State University. Could we please welcome Megan? Thank you. Mike Klinkman is co-director of Great Lakes Research into Practice Network. Mike is a professor in the University of Michigan Department of Family Medicine. He is also a practicing family physician and serves as the first director of primary care programs for the University of Michigan Depression Center. He also created the Depression Center's Primary Care Research Network. Mike has led or co-led work on the development of scalable health information technology solutions for primary and community care, ranging from theoretical work to design and testing of software applications for use in primary care and behavioral health settings. Mike received his MD from the University of Michigan Medical School. Can we please welcome Mike Klinkman? Thank you. Elizabeth Mangold is Care Connections Supervisor for Jackson Health Network. She oversees the RN transition coordinators at Jackson Health. Before that role, she was a staff nurse at Henry Ford Allegiance Health and taught nursing clinical groups from Jackson College on several medical surgical units. Could we get a couple of the mics up here, please, folks? Could you bring a couple mics up for the round table? Thank you. Sorry, folks. Ms. Mangold completed a Six Sigma Green Belt project which successfully decreased the incidence of post-operative respiratory failures. She graduated from Michigan State University with a Bachelor of Science in Nursing. Can we please welcome Elizabeth? That's forward and that's backward for your slides. All right. And last but absolutely not least, Kristen Reese, co-project director of the Michigan Public Health Institute. Kristen works at MPHI in Okemos, I'm sorry, I always mess it up, as a co-project director for the Michigan Family to Family Health Information Center, or MIF2F. MIF2F provides health resources, trainings, and information to families of children with special health care needs in Michigan. Kristen has over 17 years of experience advocating on behalf of her daughter since she was diagnosed with a genetic developmental disability at age 3, and educating and engaging other parents to do the same. Kristen has a BA in English Literature from Michigan State University. Can we please welcome Kristen?
So I just wanted, before we started, to introduce my daughter to you. I'm here on her behalf, and I wanted to just give you a little snapshot of our story, our life, and our perspective. Can I see my, yeah, there we go. So this is my daughter, Kylie. She was born in 1998. I call her my little unexpected blessing. But I had a great job. I was taking care of my 2 older kids, things were going really well, so I thought, I can do this, right? So life was pretty good for the first couple of years. And then around age 2, our world totally changed. Kylie started to regress and lose skills. Her language was not developing. Started having night terror, well, they said it was night terrors, but something where she'd wake up in the middle of the night and scream for hours and getting very disconnected. So started the round of taking her to neurology and developmental doctors and pediatrician and whatnot. And after about an 18-month journey, my daughter was diagnosed with Rett syndrome. For those of you who don't know, it is a X-linked genetic condition that appears predominantly in females and is neurological basically in nature, so it pretty much affects every system of Kylie. We've had our share of medical challenges, lots of doctor's appointments. The one picture is her having a sleep study, which I have a story from I hope to share a little bit later. But that's not who Kylie is. Kylie is a beautiful, fun-loving girl. She'll be 20 years old in July. She loves going out in her community. She loves people. And she really has changed my life for the better. And this is a couple of pictures I wanted to share of her. The first one is her when she went to prom. The second is when she went to camp. And the third is horseback riding, which she gets to do today, actually. So I think these are really important pictures to share because that's who my daughter is. And oftentimes when I take her in to see the doctor, I'm there because there's a problem. I'm there because, you know, something's wrong, and I'm talking about the things that are going on in our life. But they don't always get to see this Kylie. So I wanted to be sure up front to share with you the Kylie that I see and I know and I love every day. And then I wanted to share this with you. There was a person named Christine Lind who I think now works with NICHQ, and she created this idea of a care map. So I thought it might be helpful. And again, I'll talk a little bit more about this later, but just to show you the different people involved in Kylie's life and care. Up front, we have the medical and the health, and that involves 4 different specialists at this time, her primary care, the nurse at school, she gets physical therapy, and of course, she has to see a special needs dentist. And then different healthcare systems, medical suppliers, DME. She receives in-home services through the habilitation waiver through community mental health, and that involves having staff that come in our home every day to help provide for Kylie's care. She requires hands-on care for everything. So we have different staff that are in our home. Each company we work with has different case managers. She gets OT. And then, of course, there's our family. I have 2 older children who are both married and I have grandchildren. Baby number 4 is coming in August, so that's kind of exciting. She's still in school and will remain there until she's 26. So that involves her teacher and various professionals at that institution. There's her social and community events. She loves to shop. My girl loves Target. She enjoys swimming, going to the library, movies, and of course the horseback riding. And then also I put on here different organizations that I get information and advocacy I connect with a lot of parents through Facebook groups. There's an International Rett Syndrome Foundation, and of course other families, and the insurance and financial. She has primary private health care insurance, Medicaid. She receives benefits through Social Security and Department of Health and Human Services. So I wanted to show this because I think it's a really good visual of all the different systems in Kylie's life, and that I, as her primary care provider, have to work with, build relationships with, and coordinate.
Thank you.
And I'm not going to show the last slide yet, so.
So you want to hang out? Okay,
Yeah,
that's fine.
that's okay.
Is
Yep.
it okay if we leave it like that? for now?
Yep, that's fine.
Yep,
Yeah,
that's a good
yeah.
one. Thank you, Kristen. And then Megan Brodie is also going to share her story as well.
Okay, yeah, maybe I do have a quiet voice, so I'll try to speak up. My name is Megan Brodie, and I'm here today to talk a little bit about my experiences being a patient. I was born with a craniofacial syndrome called Treacher-Collins syndrome, and it is a genetic condition that causes the development of facial bones to stop developing at a certain point. And so a lot of the characteristics of Treacher-Collins include things like a cleft palate, underdeveloped ears, which can cause hearing loss, a recessed lower jaw, which a lot of times causes a restricted airway and breathing problems, and other just kind of facial differences. When I was born, 1991, the doctors in the delivery room had never heard of it. It's pretty rare, and it was just about a year ago that I actually met somebody else with it for the first time. So it is quite rare, and I'm excited to share more about my story and my journey, but I'll let the other presenters kind of introduce themselves and talk a little bit more about themselves as well.
There we are. Thank you, Megan. Also, Mike and Elizabeth, if you want to just introduce what you're doing and talk a little bit about what you guys are doing in Jackson, and then we can start having our discussion.
I might need to yell.
No, not that one. There we go.
Hi. This is about as far from a fireside chat
Well,
as I can imagine.
yeah,
folks,
we
so just getting that out there on
it's
the
just
table.
imagine a fire. Imagine that there's a
Yeah.
fire right there.
Yeah,
and there's,
with people gathered around so we can have intimate little conversations. Yeah. Okay. So my name is Mike Klinkman, as we said, and I've been working to try to figure out all the different ways in which connections have to happen for people that have, on one side, exceptional health care needs, but on the other side, people who just have ordinary health care needs in a system that is so complicated and so fragmented that you have to think about not just the medical data that you're passing around, but also the other stuff, people's lives, social needs, behavioral health needs, the things that are often hidden. And those are the ones that are sometimes not so high on a priority list or a checklist of things that you have to connect. So as we talk during this session, we're going to talk about the exceptional needs because I think it's a great place to start. But I also want you to be thinking in the back of your minds about what happens to everyday people who are just muddling through and how we either do or don't effectively link to help people muddle through better.
I'm Elizabeth Mangold. I actually work for Jackson Health Network, one of the provider organizations that employs care managers. And it's been really exciting to do this for the last 3 years because it's developed and changed so much from being more telephone-based to now being in the provider's offices and being able to connect with people in a much stronger, more intimate way. And I think one of the important things I want to build off of what Dr. Klinkman said is it really is everybody. You know, it's not just people who have some condition that most of us haven't heard of. It's people who have diabetes and congestive heart failure, and you know, it's a little bit of everybody. So it's not an easy system to get through.
Thank you very much. So I think where I'd like to start, if it's okay with everybody, is just, and maybe with the patients first, what are the challenges that you're finding today in navigating the healthcare system, getting information to and from the providers that you're dealing with? I think probably you both deal with a number of folks, right? So, and let's just pass the one mic probably back and forth on that one. And either one of you can start, whoever would like to start.
I think probably one of our biggest challenges is the fact that the majority of providers that we interact with work in silos. We live in Lansing, and I know when Kylie was a little bit younger and we were still in the pediatric system, there were not a lot of pediatric specialists in the area, so that meant we had to go to either Grand Rapids or Ann Arbor. And it was challenging because they didn't always talk to each other, and I would sometimes get, different information or different directions. That's probably one of them. The other is that there's a lot. I say I have a very paper-intensive life. There's always forms that need to be filled out. There's always, appeals and prior authorizations and prescriptions for medical supplies and wheelchairs. And I always say having a good doctor is wonderful, but having good office staff is like gold. Because those, having people who can get these things moving. But it's like no one interacts with each other, and if paperwork falls between the cracks, I'm the one that has to call and follow up and see where it is and what happened and different things. One example I thought of it, as I said, about her sleep study is Kylie was sent to Mott's to have a sleep study with an EEG, and we went and got results, and next thing I know, I'm getting information that she needed to see a neurologist at Mott's, and because she had spikes in her EEG, which is actually very common in her syndrome, and we knew about this, and I was like, well, wait a minute, she already sees a neurologist in Lansing, and it took quite a lot of convincing to get them to understand that I just needed the information sent to her doctor here in Lansing so that we could decide whether or not we needed to incorporate something different into her treatment plan.
How did they send that information to the doctor in Lansing once you went through
Paper.
Paper?
Paper.
Did you have to transport it yourself?
No, I didn't.
Okay.
I didn't. But the other thing is I've learned over the years is I want a copy of that paper too, to make sure that I get a copy of everything, because there's been times where things have been listed in there incorrectly, or things were left out that were really important. So I've learned. So I have, like I said, a very paper-intensive life. I have lots of stacks of it all over my house and filing cabinets and things. I can usually find it if I need it, but it's really challenging and overwhelming at times.
I'm struck by how complicated it's been as a parent, and Megan, for you, your story too. It's when your parents were working with you when you were in your youth getting all this stuff done, that the role of coordination is on you. It's on you as a parent, it's on your parents, it's now on you as an adult, Megan. How does that work when you are interacting with various disconnected pieces of the healthcare system, and how much time does it take, Kristen, for this?
It takes a lot of time, and mind you, I was a single parent raising 3 kids and working full-time. So it was like I had another full-time job on top of having to deal with Kylie's different issues.
Yeah, I would add a challenge to go along with your question is, Church of Collins is very rare, and so my parents and I really kind of took the full responsibility for making sure that we told doctors, everything there is to know about me and Church of Collins, because most of the time they had never heard of it, let alone treated somebody else with it. And so that responsibility was a lot, but on a personal note, it was also very emotionally challenging to hear my parents a lot of the times talk to multiple doctors and tell them what's wrong, what needs to be fixed over and over again. And at home, Treacher Collins didn't exist. I was a happy kid. I never thought anything different about myself. I was always included in school and friends, and so it was always just at the doctor's office where I was reminded that I'm different and, again, focused on what's wrong and what needs to be fixed. And so for a long time, Treacher Collins was this really negative piece of my identity because that's the context that it was always framed in. So that definitely comes along with having to be the person coordinating the care and having to tell your story over and over again.
There's one more thing that just popped up as you guys were saying this that I think is also important, and that is that you, Kristen, and you, Megan, now as an adult, are the experts. You know more about your disorders and the conditions that Kylie has than probably most any of the physicians you're likely to see. And that's kind of been the case right along. And David, I don't know, for your son, same thing. Is it, how does that work when you as a parent or as a caregiver or as the person with the condition is the expert and you're walking into a healthcare system and expecting or wanting some types of services that you have researched and know a lot about? How do you make that happen, and how much of a burden is that if you're your own coordinator?
Well, you were looking at me, so I'll go ahead and take a shot at it. There's a lot of convincing. There's a lot of being disbelieved when you walk in or somebody has a different opinion about the condition than you've learned. Maybe they're better informed than you, but probably they're not. And you have to convince and talk to and convince and talk to. And we were stunningly fortunate. We did a lot of traveling across the country. We were stunningly fortunate to find a very open-minded primary care physician in our hometown who worked very closely with my wife and has been wonderful. But this is a very fascinating area when we're talking about health information exchange and health information technology. We talk about standards, right? We talk about we have to have standards and their quality measurements and the quality of care. But when you're in, especially in these complicated situations, how do you account for the expertise of the patient? And I think that's a fascinating question. I really do. How do you account for that patient input and the patient knowledge that they've gained over time? Let's move this down a little and see if that helps. There we go. But I wonder then, with patient portals, have you guys seen anything change? Like, do you have patient portals now with you talk about trying to convince the one clinician or physician that you already have a neurologist, and please use the one I have already. Do you have any electronic access to anything to help facilitate that discussion, or just show them, look, here's my neurologist? Is there anything available to you now to do that?
When we went to U of M, there was a patient portal, but I did not at the time, and it was a couple years ago, experience it really helping to communicate with doctors that were in Lansing. And sometimes I think, if I can steal from you when we talked at lunch, is you just want to talk to a person. You know, you really need that connection of a person that cares, that, like I said, the office staff that can get things moving. You know, it really sometimes, I think, is both helpful and challenging. As far as communication, we too were blessed with a very good primary care provider who really actually functioned oftentimes to manage a lot of the specialty care needs Kylie had, just because I was a single working mom and taking an entire day off to go to Ann Arbor to see someone. Really, it wasn't that I didn't want to, I couldn't. I missed a lot of work with her needs, and she doesn't sleep, for one, period. So, you know, it's been really hard that way, but having a doctor who really supported us and really understood that. And so, you know, with the doctor, I had a way to contact her, and she knew and understood that I wasn't going to call her or email her with something minor. We were really lucky that we had someone that trusted us, recognized our expertise, and that we were able to connect with very easily when it truly was a situation that required some urgency. So, and I want to add too, not to hog the mic, but I work at Michigan Family to Family Health Information Center, and one of the projects that we work on is a training for families called Care Coordination Empowering Families. And it's a day-long training. We have various funders that we've been able to find to support it. I've done about 30 of them, I think, at this point, with probably about 20 parents in each training. And if I could show my last slide.
Sure, absolutely.
The very last slide. I might have to advance it. Yeah. That's the one. So, no, I can't see it. One of the things we do is we ask families when they're coming into the training if anyone helps them coordinate your children's care among the different doctors and services. And out of the, I don't know what it was, I don't have the number in front of me, 310 people who responded, the majority, 226, said no one helps them. And I will qualify that by saying these are families that have come into a self-identified the need for some sort of care coordination training. But we spend a good portion of the day talking to them about you are the expert and kind of helping build them up in a way that they understand that they're a partner in their child's care, but at the same time respecting the physician and their expertise. It's not that you're the person who knows everything, because I'll be the first to admit I don't. But I've been blessed to have pediatrician and other specialists in her life that have allowed me to be truly a partner in her care.
Yeah, I think for me, feeling like I'm the expert can be empowering and also very uncomfortable. And maybe it's because I have an authority issue. I like to respect adults and authorities, and I see doctors as they should have all the answers, and I don't want to tell them how to do their job, but I'm getting better, and my parents did not have that problem. They were very good at telling the doctor how to do their jobs, and thank goodness, because it saved my life multiple times. When I was 6 weeks old, I was home from the hospital, things were going pretty well, and I'm telling this story from my parents' perspective. I don't remember being 6 weeks old. And they would lay me on my back to change my diaper or whatever, and I would stop breathing and turn blue, and my mom thought, that doesn't seem right, So she called the doctor and said, this is happening, what do I do? And the doctor's like, oh, that it happens, that's okay, just keep an eye on it, learn CPR. So my parents became CPR certified, and that very night it happened again, and they could not revive me, and so I was rushed to the emergency room and given an emergency tracheotomy at 6 weeks old, and so it's just one example, and I had to trach for 2 years, and it was very difficult, but I just think about if my mom hadn't taken the initiative to just say, that doesn't feel right. And I think a lot of times the patients and the parents, they really are the experts. And sometimes as a parent, it's uncomfortable, or as a patient, it's uncomfortable to trust your gut over what a person with a doctoral degree is telling you.
So one of the things we're taught in care management training is how the patient is the expert in their own life. So how much would it help to have somebody that's able to advocate with you and for you?
Yeah, I think that would have been super great. I was a part of the early on program in Michigan, and they were great. They really supported my parents and empowered them to be telling the doctor what to do and what to say, and really teaching them how to advocate, and kind of like you said, helping them feel like they
Have an
are the
additional
expert.
voice.
Yeah, exactly. Yep, and they would do, anything. They would come to the home 2 days a week, and if my mom needed help giving us a bath because she was busy and she just was stressed, and that was what she needed help with that day. That's what they would do. And so, yeah, definitely having somebody or an organization there to empower you and just validate whatever you're experiencing at that moment, even if it's not pretty, that's definitely very helpful.
So I'm going to break in with one more sort of aphorism that might make sense here, and that's your experiences and even everyday folks' experiences are that people move between organizations. So for their care, every bit of care isn't done by the medical system in your patient-centered medical home. Every bit of care isn't done by the consulting expert, in your case, with the most knowledge about the condition. Your care may be provided by multiple community service agencies, private folks who are helping, volunteer groups, advocacy groups. All of those organizations live in islands in terms of their information management. And this brings it back, David. We'll get back to, see, we're getting back to—
I'm good.
yeah.
I'm enjoying it.
But trying to figure out how an information technology solution can bring together the organizations at a way that makes sense so that, you know, everybody has some idea of who's involved. Can you go back to that slide? So that's the situation, folks, out in the audience. I mean, those are the people that are involved in Kylie's life kind of day by day by day. How do you connect them so that people who are doing the red stuff know what people who are doing the blue stuff are doing and that they don't work at cross purposes? How do you just make sure that the minimum amount of connecting happens and it's facilitated so it doesn't all live on mom's shoulders to manage, or so it all doesn't live in the very well-intentioned work that somebody like Elizabeth does trying to assemble that information, because it's a lot less efficient for Elizabeth, who doesn't even know all these folks, to try to figure this out than it is for Kristen to tell Elizabeth. You begin to see how complicated these chains of communication are.
Yep.
And how challenging it is for a low-tech, simple, nut simple solution to make this work.
I'm curious how much Elizabeth and Kristen, you had mentioned the teaching the care coordination to folks. How much does technology play a role in that at all? And the work that you do as your job and the work that you do teaching folks, are there solutions you tell people about now?
One of the things in the training that we hold, it does come up. One of the sections is on organizing information. And one very interesting observation, most of our funding is open to families of kids between birth and 18 or 21, depending on who our funder is. But I did one particular class in Macomb County that was funded for families of kids with autism. And it was, I believe, they had to have a child 10 and under. And we don't go in there and tell them how they have to organize information. It's one of those things. We give them some suggestions. We, share ideas. We share resources. But it's one of those things that everyone kind of really has to develop their own. But in that particular class, we talked about having a care notebook, and we asked, did anyone have a care notebook? And man, you'd have thought I mentioned something in another language or something. They just looked at me like, what are you talking about? We have apps. And I was like, that was really eye-opening to me, because I was from an era where we had care notebooks.
Yep.
And they all kind of looked at me like I was, losing my mind when I talked about it. Did anybody have a care notebook? They're like, no, we have this app, and we have this app, and we have our health portals. And so I think it's heading that direction, but it doesn't work for everybody. Not everybody has the tech savvy, not everybody has I think I'm pretty lucky in that I'm college educated, I'm white, and I speak English. And I think about the different challenges that I've experienced in navigating the system with basically a lot of positives. And I don't think that for families that have even one challenge in those areas, that they have the same experience.
Yeah. Thank you.
So as part of care managers' roles, we do try to, get patients connected or families connected to some of those apps and some of the different websites and things that are out there. But just like Dr. Klinkman said, those things are like an island. So, they live on the phone, but that doesn't mean their provider knows about it. And sometimes they do, and sometimes they don't. And sometimes that information is really important and it doesn't get where it needs to get.
Yep. They couldn't hear the question.
So how often is that an issue when you're trying to work with your clients?
Pretty frequently. I mean, I don't have an exact number, but
Is there any solution that you can give them now? Is there anything you can tell them? Or what do you tell them?
well, then that's when it's my job to get the information from point A to point B.
Right. But it's still a human making sure it gets done. Yeah.
Yeah. Yeah.
Megan? Yeah.
The only thing I would add just really quickly is I love, Elizabeth, when you said, you know, we have pretty complex cases, conditions that aren't very well known, but I think in the disability community there's a phrase that says, you know, what works for somebody with a disability works for all people. And so if we can create solutions that work for cases that are very complex and cross state lines, and, you know, because we want to go wherever the specialists are, then that will also be helpful for people with less complex cases as well.
And if I can get my plug in here for parents, but I think it's really important as you look at solutions is having the people who use them be a part of the team creating those solutions. I don't speak for every parent. I don't speak for every person that has a child with a disability. And my experience is unique to me. So, but I really truly believe that if you're really going to have anything that's meaningful for families or patients, that you involve them in the creation of the solution.
Let me go off reservation one more time. When we were talking earlier, we kind of blew things up and we kept talking about other stuff. But the other piece I think that may not be clear in our conversations that I'd like to make clear is that this is probably not a medical enterprise only solution. These folks that we're talking about, you know, the examples you've given up here are examples of people who had sometimes primarily medical issues, but as you could see from Kylie's example, there are, in the end, multiple people involved in a system of care that work largely outside of the medical envelope. And so I've been part of too many efforts that have tried to build technology into an electronic medical record to do this work that fail because you simply can't maintain all the connections you might need to maintain to make this work in everyday workflow. So the plea here is to think about solutions that go outside of that medical envelope and can be effectively implemented in broader settings. And I think that's kind of the message that MiHIN wants to get across in a lot of the work that they're doing as well, which is let's do things that work more broadly and more simply that can engage more caregivers in what winds up being quite complicated care pathways.
Dr. Klinkman was not compensated for that comment. I just want to make sure. That actually does lead to a question that I wanted to ask. Where do we start then? Where's the best place to start? Like, if you could pick one thing that would help you as a patient, or you as a care manager, or you as a physician, and these may very well be different things, but to coordinate that care better. We have admission, discharge, transfer notifications flowing through the state. We had medication reconciliation messages. There's a lot of good information flowing. Obviously, there's still lots of room to grow and lots of things to build. But if you could pick one thing, what would you pick? What would help you the most? Anybody just jump in there.
So I'll say most of my patients don't just have medical issues, like Dr. Klinkman said. Most of them have a lot of different social resources they're using, like having DHHS and, you know, different things that are helping with their care. But there is nowhere in the record that you know that. You only know that by communicating with the patient. And if the patient is not as good at advocating for themselves as these two have been, you get very confusing information or huge gaps in what you should know. So I think if there was any way to get the social information more accurately, you know, to the people who need it, that would probably be where.
So that connection of the social to the healthcare, so that we can at least tie them and get a little bit more holistic view.
It's like Maslow's hierarchy of needs. So when you have people who can't feed themselves. They don't care about their medical conditions.
Yep. Very well said. Good point. Other thoughts on that? What would help the most?
I'd like to hear from our patient side folks too before I launch.
They're considering it very deeply.
I'm thinking
Yes.
about it. And I thought about this before I came, because it's one thing to just talk about what some of the challenges are without offering any solutions or thoughts. I think for me, and I'm going to reveal my little bit of a control freak side, but you know, me having access to all the information, because ultimately I am the center of all those different spokes. I mean, my daughter's the patient, but in terms of her care, I'm the center of all that. You know, having things like our care coordination training for families, but having access to her. I mean, there's so much that I can't, and that, like I said earlier about having her a good office staff, you know, finding those allies, as I call it in our training. You know, it's so important to have good relationships with them, but there's so much that I can't do. I can't file a prior authorization, you know. But if I had...
I wish you could.
You know what, I do too, actually. Yeah. I do too, because there's nothing worse than not being able to get your baby her medicine. You know, I have a great relationship with our pharmacist, and luckily they've always kind of helped me through. You know, but helping that primary care provider learn how to build those relationships, and you know, we talk a lot about that in our training, because it is about a lot of relationships, you know, that you have to have and build, and regardless of who's involved, like I said, that patient or that primary caregiver is still the center, and really helping empower them, whether you're the care coordinator, but really helping and working with them to empower them, because no one else is going to be that center in the end. You know, I've had times where I've been trying to get medical information, and I have to call, and I have to sign releases, and I have to, you know, it's so challenging sometimes for me to go through all those hoops. And like I said, I have a pretty good skill set. I'm quite persistent, but not everybody is, so.
My answer is kind of a combination, actually, of Elizabeth and Kristen's. One, I get really excited every time people in this field talk about social determinants of health, because I think it's so important to see the person as a whole person, and you know, understand that it's not just somebody with diabetes. You know, they have things going on in their life that probably impact their ability to take care of themselves, and it's important to look into that. And then also having access to the information for ourselves, and really just knowing that medical professionals, as well as health IT professionals, are really listening to what the patients are saying. And I think it would be helpful to have evidence of that, and see, you know, studies of health IT professionals and medical professionals reaching out to the patients and really doing more interaction in terms of coming up with solutions.
I will put in a little plug then for some of the work we have done in the Jackson community before and during the SIM demonstration project. Does the audience know what SIM is, the State Innovation Model? Briefly, SIM is CMS-funded demonstration project to work to better integrate care between medical and social issues, being undertaken in 5 communities around Michigan. We're about halfway through that project, and Jackson's one of those communities. And we intentionally entered into a painfully slow process of working directly with community service agencies, community lay members, the existing sort of caregiving entities in the Jackson community over the period of about 18 months to have conversations about how is it that we would want to coordinate or communicate about taking care of people that we share. So this was not a medically driven approach. It was intentionally light on the medical side so that the community sort of organization could emerge. And we went through a very rigorous process called socio-technical design, so we would co-create that infrastructure that worked. And the goal is that it does meet the needs of that local community so that the everyday things as well as exceptional things may have a pathway to at least get the caregivers together. And it's pretty modest in terms of what it does, but the intent is to do exactly what you guys are talking about.
Thank you. I would like to take time. We have about 12 minutes. I'd like to open it up for questions as well. So any questions from the audience? I see one over there. It is very hard to see into the audience with those lights. That's interesting.
Hi, this is on?
Yep, you're on.
Okay. Kathleen Connor, I work at HL7, and one of the groups that we work with started out as an O&C project called eList, or Electronic Long-Term Care and Social Services. The whole point of that is to turn all of the needs that you're discussing, they have a huge plan of action, into FHIR resources, so that you can do things like possibly you got a paper form, they can convert that into a FHIR form, which can then you could automatically populate. You don't have to re-enter your information, and you can send it. You can parse it into observations and consents and everything else. You can sign it. So I would really recommend that perhaps some of you, I can give you the information about how to get a hold of them, but they are listening to patients. They are listening to exactly the kind of use cases that you bring up here.
Thank you, Kathleen. I think we would be interested in having that info. Thank you again. Other questions?
Oh, do you mind if I hold it? Okay. Hi, thank you so much for your presentation. I'm also a parent of a child with special needs, and so much of what you said resonated. And I just wanted to reflect back some of the themes that I heard, in that what keeps coming to my mind is how to make the system a trauma-informed and more supportive system. Thinking about, Megan, what you shared, how the worst part of your experience was listening to your parents have to tell the medical providers about how bad the situation was, when in other parts of your life it was positive. So how do we make patients' experiences of entering our systems a positive and affirming experience? I've had my own experience having to put headphones on my son while we're talking with the doctor, so he's not absorbing the conversation. And I think about how that translates to the written information that we generate in electronic systems, of how do we document in a way that is empowering, so that if patients were to read their records, they could feel affirmed by what they read and not stigmatized or kind of further traumatized by this experience that's already so emotionally draining. And then the other part I heard was from Kristen about having to retell the story again and again and again, and how that in itself is like re-traumatizing. So the more we can set up the system to avoid having to do that, I think could be really powerful. And then the other theme I heard was around the lack of control over the information. It's like when you don't have the ability to do the prior authorization or to get the referral or the report that you need, like how do we empower patients to have more control and access over that information? I think that's another powerful theme. So I just wanted to point that out, that for me, having had a background in trying to build trauma-informed systems, that there's a lot of synergy in what you shared. And thank you very much.
Thank you very much for the question. I'm going to break that down into two. First, the trauma question, as far as I've experienced the same thing, by the way, with my family, that in the discussing of the condition can be very traumatic, and over and over and over again. Is there anything we can do, and to keep with the theme of the conference, technologically, and maybe the answer is no, to help with that at all? I wonder if we're designing patient interfaces in a way that allows them to understand what they're looking at.
this is a huge issue coming from a background that I've had in behavioral health as well. There was a lot of resistance when the idea of moving treatment notes or any notes from any psychiatric caregivers or therapists became part of our integration of our own healthcare system. And I understand the arguments on both sides, because a therapy note is a fairly personal intensive document, and it reflects some of the work done cognitively by the provider as he or she is interpreting and trying to make sense of what they're hearing. So there's a lot of stuff in there that makes sense to a therapist that could be harmful or traumatizing to the person who is receiving therapy. So that occurs almost unknowingly across the whole medical spectrum. I had last night in patient care, a patient who I've known for 30-some years came in with a horrible story about being given the report of a medical study that contained some fairly inflammatory, fairly destructive implications that may or may not be true about long-term cognitive disorder that was maybe suggested by the result of the test. And that's how she first learned about it, because it was just thrown on the portal. And then she also saw the notes and the discussions back and forth between the specialists who were trying to interpret it, because she had access to the portal, without any direct conversation about what that meant for her. This is a very intelligent, very informed person who was traumatized and outraged by that level of speculation in a medical record that had a direct bearing on her own perception of her future well-being without any discussion. Now, there's two sides to that. One side is it was necessary, I think, for the medical professionals to have conversations about that, and given their workflow, they don't have necessarily time or space to arrange a face-to-face meeting, do this off the record, put some distilled commentary in a note that might then be consumed by a patient. But on the other hand, how much of what is out there is it possible for a layperson to see without either misinterpreting or being sort of harmed unnecessarily by exposure to that? There's an ethical dilemma there that technology won't solve, because our solution so far has just been, well, if it's on the portal, you can see it. And then expecting every clinician to somehow change his or her approach to working with that information so that they self-censor before it might go out to a portal that everyone sees also has a downside. So that's way beyond where we're at here, but that's a hard issue.
It is, and it ties then directly into the second part of that question, which was patient access to their own information. But if you, and I think at least most of the folks in the room would agree that we do want patients to have as much access as possible, but then if that access is to information that they don't necessarily understand, or that they weren't participating in the discussion, are we causing more trauma? That's a difficult problem. I'm very curious to other thoughts on that, but that's fascinating. Any of you? Yeah, Kristen, go right ahead.
Well, I just wanted to add the other issue of, I think of my own personal life. The majority of Kylie's care is either medical or through our community mental health, developmental disability services, the waiver that provides her in-home care and respite and various other services. And I've been lucky that I've had a very positive experience. I'm happy to sign the releases. I'm happy to let them talk to each other, but I'm operating from an experience where everybody and I got along and everything went well. And I hate to say I had a friend but I had a friend that didn't have that same positive experience. And I think sometimes people don't want everybody talking, and there are people who have different levels of comfort with having everybody talking, and with experiences of believing that everybody who's talking has their best interests at heart.
Yep.
So that kind of muddies the water a little more, I think.
Yeah, thank you. I love your comments. I'm a social worker, so I'm all about the strengths perspective, and thank you for that. And I think I've had probably close to 12 different surgeries, and I wear a hearing aid and been through a lot of medical trauma, but really it's the emotional trauma that is so much harder to recover from. And so I hope there's a technological solution, but I wonder if before we can even get there, we just have to have more of these conversations and kind of widen our viewpoint of how to really care for somebody in a holistic way.
Wonderful, thank you. We have time for one more question. Anybody else?
I really don't have a question, just a comment. Cultural competency and health literacy, until we challenge, and not challenge, but until we begin to overcome some of those issues, the IT component is really not going to work well. I usually stress the fact I'm an immigrant. English is not my first language. And so when I work with my own first language community, a lot of what we're doing in the IT level just will not work. So we have to put people before we put IT solutions in place.
Thank you. I agree.
Thank you. We still have time for one more. See one in the back there? Yep.
Mary Graham, Great Lakes Health Connect, and I so appreciate what you were saying about working with your community mental health. I have 13 years working in CMH, and when I was there, we started what we call person-centered planning. It predates patient-centered medical home. And while you were speaking, both you and Megan, and of course your family experiences as well, I was thinking back to Dr. Stepanek yesterday, and his story about how he was very family-focused, and he reached out to his patients himself, but he treated them as people. And when we frame the service as person-centered planning, that's different than a patient-centered medical home. We have now put the person at the center, and we're not treating them as a problem or a specific kind of person. So following up on what Eva was saying, it's about treating people as people, not as problems, and we have to start with that and not the tech. I think that's really critical.
I think that's why I brought those pictures of Kylie that I brought, was so that, you know, I'm not just standing up here talking about our challenges and our problems, but showing you some of who she is as a person, seeing her doing community things and being, you know, doing everyday things that people her age do.
Thank you. I believe we're out of time, so thank you folks so much.